Hi, I'm Scott Hackenbrook. I am recording this from a top secret COVID-19 survival bunker. As you can see, I have all the essentials behind me. I apologize for the audio. I'm still working on the my recording abilities, and it'll improve over time. I'm a physician assistant who's worked pulmonary medicine, chronic and interventional pain, and remote medicine in villages in Alaska as a sole provider. While out there, you work with a hub and do some telemedicine with the hub, but basically, when you're out there, you're out there. So anyway, I'm also a respiratory therapist, or I worked as a respiratory therapist in the hospitals and in critical care, ICUs, and all over, some home care for about 16 years before becoming a physician assistant. I was asked to put together a video with some thoughts for first responder pre-hospital setting for those of you that are working on the ambulance crews. So I'm going to start off with some general thoughts from my perspective, and then I'll get into a little bit more detailed recommendations from a couple of different sources, and you can go as far into this video as you like. First thoughts. Irregardless or regardless of your level of concern about the current coronavirus situation, some people are very concerned and very worried, and I would say even to the level of panic and outright they're outright terrified, and some are completely disinterested and feel like it's a non-issue. In the job that you're in, that is something that you need to mitigate in either direction, or either end of the spectrum that you fall in. If you're extremely fearful, you need to calm that down and transmit calm and confidence and competence in what you're doing. If you are cavalier, you definitely need to not transmit that, or the person that you're caring for will not have confidence and will be afraid of you. Me personally, sharing this with you so that you understand where I'm coming from, I'm probably in that spectrum of cavalier to fearful. I'm definitely left of center on that. On the I won't say not concerned, but I'm definitely not in the fearful category. But when dealing with others with regards to this, I have to mitigate that, though I want to transmit a sense of calm. I don't want somebody to see me as part of the problem. And there are some people that are so frightened that definitely can happen. In fact, I will share something with you along that regard. I hadn't planned on starting out this way, but we're gonna do this just how it comes. And apologize for the shakiness. I've got these monitors on one of those adjustable stand-up tables, and as I touch this, the the big camera monitor shakes, so I apologize for that. But I have to move the mouse every so often. I posted as an attempt to try to reassure people. I posted something on a neighborhood forum here in Anchorage, Alaska. Let me move over to that real quick. I gotta find my controls here. There we go. All right. So I posted an attempt at perspective. I had read something by a Valerie Ross, an MD in emergency medicine. I don't know for certain, but I think this doctor is in New York, and I quoted her. "We still have absolutely no idea how many infected individuals had no symptoms, or symptoms so mild they didn't bother coming in for testing. Once those numbers are added in, the case fatality rate will plummet. These numbers are the fatality rates for those who are quite ill to begin with." End quote. So continuing with my post, this does not diminish the severity for those who have been severely ill, and especially not for those who have died, but likely does diminish the severity for the general public as a whole. The level of fear and terror is out of proportion to even the current numbers, and certainly to the numbers that the above statement may end up showing in the end. Wash your hands. Stay at home from work if you're sick. You should have done all these things. You should have done all these things all along. And to protect the vulnerable, keep a respectful distance from others for now. But take a deep breath. No pun intended. Calm down. No need for the level of fear that I see in so many people's eyes. Now, if you listened to what I said there carefully, I didn't recommend anybody to be casual or reckless in their dealings with this. I did say wash your hands. I did say stay home if you're sick. Stay home from work. Keep the social distancing. Distance from people. Protect the vulnerable. But it's okay. Calm down. No need for the level of panic and terror and fear. And I got ripped for this. One individual in particular, that's the problem. People are passing it around without symptoms. Then you bring it home to family members who have underlying health problems. It's better to overreact than underreact. With your attitude, you are not welcome to my home. You are dangerous. There was a few more comments, but I'm gonna stick with hers. My opinion is you first. Go right ahead. I hope they aren't short on supplies and tell you sorry, saving you would use too much resources. We'll make you as comfortable as possible. And then I got a private message on that, and deadly advice. Being a doctor, I don't know how she figured I was a doctor, but she somehow knew that I was in the medical field. I cannot believe that you are sending out such deadly advice. Shame on you. And so people can definitely overreact if you don't transmit. If you look like you're being cavalier. So if you fall on that end of the spectrum, it's okay to present calm assuredness. It's even okay to share an opinion that this may not be as bad as the level of fear of it has been. But I would even be cautious about that, particularly while performing your job, because your job is to have compassion and take care of people that are sick and that likely are terrified given the current climate. So there's more that I could say about that post, but I'll leave it there. And then the other thing I would say is that if you are especially fearful, both sides have to come closer to the middle, be professional, and the patient's wellness and state of being is going to have a lot to do with what you transmit, with what they feel, the vibe, if I can be unscientific, the vibe that they feel coming from you. So that is very important. And I hadn't planned on spending that much time on that, but I do think it's important. And it's something that you just have to, if you're going to care about people and take good care of people, you have to keep that in mind. So enough of that. What next area? What do you do? Well, the coronavirus is a generally speaking, we're talking about general droplet precautions, and if you're in the line of work that you're in, you should know what that entails. Droplet and contact. So lowest level of protection would be a surgical mask, goggles or a face shield, a disposable gown, potentially foot coverings, booties, and hair covering. If somebody coughs or sneezes and projects a droplet, you're basically trying to be covered so that you're not going to carry that, but mostly it's about inhaling it. Next level up, especially if somebody's symptomatic and if you're going to pick them up, in many cases that's going to be the case. I know you do a lot of transporting of patients, and maybe they're not symptomatic, so that's why I'm going over the different levels. But then we're looking at all of those things that I just mentioned, but switching from surgical mask to an N95 mask, that's going to give you a good seal and protect you from anything being entrained around the mask and you breathing it in. If you're going to do any kind of aerosol, such as a nebulizer treatment, an N95 mask would be recommended. If you have facial hair, and if you looked at the picture on my channel where you found this video, you'll see that I had a beard. I like my beard for multiple reasons. I've recently shaved it off. One of them being that it's a lot easier, is probably understating the ability to wear a protective mask like an N95 mask and have it actually function and do the protecting that it was designed to do. You don't need a full Santa Claus beard like I had grown nearly. Just stubble will make the N95 mask similar to your surgical mask. You can still entrain or suck air around it. Basically, it's like tuberculosis or TB precautions. When they test to see if you're going to have a good mask fit, there's different ways of testing that. One of them is where they put the hood on you and you put the mask on, and they shoot this awful tasting or sweet tasting spray in there and have you breathe in and out heavily and see whether or not you taste it. That's because you can pull, if you have any break in the seal, you can pull those particles in around the mask. And so if you sport stubble, that's something to consider, that you're not protected by that N95 mask the way it's designed to work. So for the short term, you might consider being clean shaven. It grows back, okay? So that's not a mandate, as we're just talking here. It's between you and your loved ones and your employer. So a lot of places are going to meter dose inhaler in lieu of nebulizer. And if you've done this kind of work for any amount of time, you'll know that that is highly technique dependent. As a respiratory therapist for, well, it's been over 2 decades now, though I shifted from RT to PA after about 16 years. I can say that if I did not think that they had good technique, that squirt, that meter dose didn't count. Only the ones that I felt like they got, a good deep breath, didn't plaster it against their tongue or the back of their throat. Those are the only ones that counted. It's not like a pill where as long as you swallow it, it's good. It's got to be carried down into the lungs, and so it's highly technique dependent. Now, if you have to use a meter dose inhaler, a spacer greatly reduces that level of technique dependency. And for somebody that maybe it doesn't even do well with the tube spacer, putting it in their mouth, you can always consider the meter dose inhaler, spacer, and a mask, the way you would do with pediatric patient. And when all that fails, there's a reason why nebulizers exist, and that is because it gets down in there a lot further over a longer period of time. So if you have to use that, you definitely want to be protected. And if an N95 mask is not working for you, maybe you got a big noggin like me, and finding one that is big enough to fit and where you can still talk and not break the seal and all that type of a thing, or you just have a glorious beard that you're just not going to part with, then a PAPR device is really what you're going to need in order to be protected. Now, if you fall on that other end of the spectrum, the more more towards cavalier, or which is really a bad word for me to use, but more toward that end of the spectrum, less fearful, you may not be as concerned about yourself, but you need to be concerned about the fact that you can pick this up and you can transmit it before you become sick. And you might only be mildly ill. In fact, many people are. But you're dealing with a patient population that isn't necessarily so. And so you have a responsibility to keep yourself well for the sake of the people that you're taking care of. Not only them, but your loved ones. I have a duplex here. My parents live on the other side. My mom's 80, my dad is 75 and has COPD. I'm not afraid of this thing. I don't walk around in fear. I have a respect for it, but I'm not fearful. Um, but I definitely don't want to carry it to them. And I have to interact with them. You know, they don't live in the same unit, but we definitely live under the same roof, and we're a family. We're taking care of each other, so I can't just not see them or interact with them. It's as if they're living in the same unit or whatever. So I have to keep myself healthy. I have to keep a respectful distance, even though I'm not enormously fearful for myself. I am very concerned, just as I would be if there was a bad flu going around. And you know, that could the coronavirus, COVID-19, or a bad flu could take out one or both of my parents at their age. So there needs to be, if you don't have a high level of concern for yourself, you need to have a high level of concern of keeping yourself healthy for your loved ones and for the patients that you're serving. So, now so nebulizer. Another thing that you can consider is double gloving. Why would you double glove? Well, because if you have two gloves on, you can, let's say you're going to get rid of a nebulizer. The patient's gone. You're going to double bag stuff that they used. Whether it's the covering for the gurney or your PPE, your disposable gown, your hair net or hair covering or whatever. Let's say you put all those, you throw all those things away, and you're going to double bag that. Then you're going to take off that first layer of gloves, and you still have another glove on. You haven't exposed your skin, and now you can take your purple wipes and wipe down all your other things. Or let's say you need to handle a clipboard, that you were handling, and you haven't had a chance to wipe it down yet. Having the double glove on gives you a chance to get rid of the dirtiest glove and still have some protection while you're disinfecting everything else and getting ready for the next run. Ambu bags, of course, are disposable. You're going to get rid of those if you had to bag somebody. Some places are using filters on the exhalation side of the Ambu bag, so that you can filter out, potential, aerosolized droplets. And I mentioned already the purple wipes that are, the nuclear wipes that you can wipe things down with that are not being disposed of. All right, so nebulized treatments, higher level of PPE, the N95 or the PAPR device. Consider being clean shaven short term so that you not only protect yourself, but those that you come in contact with. And consider meter dose inhaler if you think that it can be effective with the patient that you're dealing with. If they have good technique, if their technique can be assisted with a spacer or a spacer and a mask, and if that just doesn't work, then you're going to need to put them on a nebulizer, and while you're trying to keep them from decompensating further as you're transporting them. If you need to intubate, all of the above, and or extubate. You're not likely to extubate. That's hospital side. If you need to intubate, you're going to want to, of course, be ready. In fact, let me move over to one of my documents here so that all right. Now, this is recommendations for airway management in a patient with suspected coronavirus. Okay. And I can try to put a link to this is the Anesthesia Patient Safety Foundation, adapted from Camming D, Gardam M, Chung FI, Anesthesia, and SARS. And I'll explain the SARS reference a little later. All right, let me move on. So, general, your personal protection is the priority. Now, keep in mind that this is hospital setting, intubation, anesthesia, getting ready for surgery, that type of a thing. But you can adapt this for the pre-hospital setting as you will. Your personal protection is the priority. Personal protective equipment, PPE, should be available for all providers to ensure droplet/contact isolation precautions can be achieved. Provider and organizations should review protocols for donning and doffing PPE. Careful attention is required to avoid self-contamination. Patients with confirmed or suspected 2019 nCoV infected cases. One should not be brought into holding or PACU areas. So you're going to keep the quote-unquote social distancing going when you transport. You're going to try to not cross-contaminate other individuals or patients. Should be managed in a designated OR with signs posted on the doors to minimize staff exposure. Should be recovered in the OR or transferred to the ICU, negative pressure room. High quality heat and moisture exchange filter, HMEF. Plan ahead. Allow for time for all staff to apply PPE and barrier precautions. Consider intubation early to avoid the risk of a crash intubation when PPE cannot be applied safely. Now, that plan ahead point is something that I would like to address. The universal precautions idea, or concept, I should say. What you don't want to have happen is you to be scrambling to increase your level of protection in a situation where it's just that you're scrambling, and instead of taking care of the patient, you're scrambling to take care of your protection, or you're not taking care of your own protection in order to take care of the patient. So plan ahead, have these things taken care of before and during the time that you are not in crisis, and doing the work that you're doing. You should understand this already. Okay. During airway manipulation, disposable masks, goggles, footwear, gowns, and gloves. Consider adopting the double glove technique. Standard ASA, that would be Anesthesia Society of America. Monitoring should be applied before induction of anesthesia. N95 mask at a minimum should be utilized. PAPR device may offer superior protection when manipulating an airway of an infected patient. Assign or designate the most experienced anesthesia professionals available to perform intubation if possible. Avoid trainee intubations for sick patients. That's something you might consider on your rigs, having the person that is the most experienced and capable. Um, this briefer period where we're dealing with the kind of the height of this crisis might not be the best time to say, hey, why don't you give it a try? You might just need to take care of business. And nobody needs to be offended by that. Yes, you do. The less experienced do need to be trained. They just don't necessarily need to be trained in a suspected infected patient under emergency situation. So that would be something in terms of policy that you would need to talk to your employer about. But that's just a thought. Let's see. Avoid fiber optic. Yeah, you're not going to do that. Of course, prepare to pre-oxygenate, perform a RSI or rapid sequence induction to avoid manual ventilation of patient's lung, potential aerosolization of the virus from airways. All right. Depending upon RSI, depending on the clinical condition, the RSI may need to be modified. If manual ventilation is required, apply small tidal volumes, basically trying to keep the person from coughing droplets into the air. Ensure there's a high quality heat moisture exchange filter rated to remove at least 99.97% of airborne particles. 0.3 microns or greater, placed in between the face mask and the breathing circuit, or between face mask and reservoir bag. Resheath laryngoscope, or let's say your immediately post-intubation double glove technique. This is where your double glove technique comes in helpful. You take the outer glove off and reapply a new clean glove. Seal all used equipment, airway equipment in a double Ziploc plastic bag. It must then be removed for decontamination and disinfection. And remember, after removing protective equipment, avoid touching your hair or face before washing your hands. Important point. So that was just a document from the Anesthesia Patient Safety Foundation. All right. So let's go back over here. I've got Internet Book of Critical Care. And it is on COVID-19 updated 4/6/2020. So that'd be today. This gets a little long, so it might, you might be done, or you may be interested in continuing on. But I want to go through this, and some of you may be much further versed in all of this because you've been interested enough to do your homework, and others this might be the first on this level that you're getting. COVID-19 is a non-segmented positive sense RNA virus. Okay, it's part of the family of coronaviruses. So this contains 4 coronaviruses, which are widely distributed, usually cause the common cold. Okay, so when you hear somebody say a coronavirus is, it's the cold. Well, yes, it's part of the family of viruses that usually cause the common cold, but it can cause viral pneumonia in patients with comorbidities. If you remember recent history, there SARS and MERS, these caused epidemics with a high mortality rate, which are somewhat similar to COVID-19. COVID-19 is most closely related to SARS, okay? It binds to the ACE2 receptors located on type 2 alveolar cells and interstitial epithelial cells of I believe of the intestine. This is the same receptor used by SARS, hence the technical name for COVID-19 is SARS-CoV-2. The original SARS was SARS-CoV-1. So when considering possible therapy, SARS, aka SARS-CoV-1, is most closely related to virus, is the most closely related virus to COVID-19. Now, COVID-19 is mutating, which may complicate matters even further. Virulence and transmission will shift over times in ways that we cannot predict. New evidence suggests that there are roughly 2 different groups of COVID-19. This explains why the initial reports from Wuhan in China described a higher mortality than some of the most recent cases. Okay, so I'm going to move down a little bit. Nomenclature used. Technically, the virus is supposed to be called SARS-CoV-2, and the clinical illness, okay, when you get sick with it, is COVID-19. Now, this gets confusing, so for this, we'll just use the term COVID-19 to refer to both the virus and the clinical illness. The term SARS be used to refer to the original SARS virus from 2003, which has been renamed SARS-CoV-1. What's going on? Well, pathophysiology, ARDS, ARDS, acute respiratory distress syndrome. Some of you will have been in your line of work for some time and may be familiar with ARDS. ARDS is one of the reasons for the high mortality rate. If you go into ARDS, doesn't matter whether it was coronavirus, COVID-19, or some other precipitating factor or illness, ARDS has a high mortality rate, and dealt with that for many years as a respiratory therapist. So you had somebody that went into ARDS on a ventilator, you were lucky to get them off alive. Primary pathophysiology is ARDS, characterized by diffuse alveolar damage, including hyaline membranes. Pneumocytes with viral cytopathic effects are seen, implying direct virus damage rather than purely hyperinflammatory injury. And then the second thing is the cytokine storm, emerging evidence that some patients may respond to COVID-19 with an exuberant cytokine storm reaction with features of bacterial sepsis or hemophagocytic lymphohistiocytosis. Sorry about that. Clinical markers of this may include elevations of C-reactive protein and ferritin, which appear to track with disease severity and mortality. Okay. Probably lost a bunch of you right there. Those of you that are still here. Transmission, okay? Large droplet. COVID-19 transmission can occur via large droplet transmission with a risk limited to approximately 6 feet from the patient. This is typical for respiratory viruses such as influenza. Transmission via large droplet transmission can be prevented using a standard surgical style mask, okay? Now, that's droplet transmission. Airborne transmission, well, it's controversial whether COVID-19 can be transmitted via an airborne route. In other words, small particles which remain aloft in the air for longer periods of time. Airborne transmission would imply the need for the N95 mask, which is called an FFP2 in Europe, rather than surgical masks. Prior evidence regarding this controversy is explored further, blah, blah, blah. All right. A recent study on COVID-19 demonstrated the ability of the virus to persist in aerosols for hours, making aerosol transmission plausible. So it is something that is plausible, and we need to protect against it. Guidelines disagree about whether to use airborne particles. Canadian guidelines and World Health Organization guidelines both recommend using only droplet precautions for routine care of COVID-19 patients. However, both of these guidelines recommend airborne precautions for aerosol generating procedures. Example, intubation, extubation, non-invasive ventilation, high flow nasal cannula, that's anything above 6 liters, CPR prior to intubation, bag mask ventilation, bronchoscopy, and tracheostomy. Next group, ANZICS, that's the Australian New Zealand Intensive Care Society, I think, recommends airborne precautions be used for critically ill patients with COVID-19. The United States CDC previously recommended using airborne precautions all of the time while managing COVID-19 patients. However, the CDC recently updated their position, stating that surgical face masks are acceptable when N95 masks run out. All right, so bottom line, that's kind of a no-brainer, right? Gee, I don't have an N95 mask. Okay, wear a surgical mask. That's better than nothing. All right. The type of personal protective equipment used will vary depending upon availability. Local guidelines should be followed and local policy with your employer. Negative pressure rooms are ideal, but will be exhausted early, so on and so forth. All right, contact transmission, fomite to face. Fomite, some of you will understand that term, others maybe it's the first time you're hearing it. Fomite is my phone, screwdriver, clipboard. It's basically an object that you touch or somebody else has touched, a doorknob that then you or somebody else touches, and the transmission wasn't directly from one person to the other. It was through an intermediary object. That's a fomite. Fomite to face, okay? This mode of transmission has a tendency to get overlooked, but it may be incredibly important. This is how it works. Somebody with coronavirus coughs, emitting large droplets containing the virus. Droplets settle on surfaces in the room, creating a thin film of coronavirus. The virus may be shed in nasal secretions as well, which could be transmitted to the environment. The virus persists on fomites in the environment, depending upon the type of surface. Virus may persist for roughly 4 days. Someone else touches the contaminated surface hours or days later, transferring the virus to their hands. If the hand touches a mucous membrane, eyes, nose, mouth, this may transmit the infection. Any effort to limit the spread of the virus must block contact transmission. The above chain of events can be disrupted in a variety of ways. Okay, regular cleaning of environmental surfaces. They mentioned 70% ethanol, 0.5% sodium hypochlorite. That I believe is bleach solutions. Those purple wipes are great. Okay, hand hygiene. High concentration ethanol neutralizes the virus and is easy to perform. So basically, we're talking about an alcohol-based hand sanitizer. Avoidance of touching your face. This is nearly impossible as we unconsciously touch our faces constantly. So this is something, when I was in Marine Corps boot camp, the drill instructor would just jump down your throat if you touched your face. It just, and it was extremely hard, but boy, they trained you not to, because at that time, the drill instructor used the term, Charlie just blew your face off because you reached over there and touched it, unconsciously. So training yourself to not touch your face will take some effort and some diligence. Okay. All right. The main benefit of wearing a surgical mask could be that the mask acts as a physical barrier to prevent touching the mouth or nose. So that's an important point to consider. Now, any medical equipment could become contaminated with COVID-19 and potentially transfer virus to providers. A recent study found widespread deposition of COVID-19 in one patient's room. But fortunately, this seems to be removable by cleaning with the appropriate disinfectant. All right. ANZIC's guidelines recommends minimization of stethoscope usage. So there's something to think about. Definitely get in the habit of cleaning your stethoscope. So when can transmission occur? Asymptomatic transmission in people with no or minimal symptoms appears to be possible. Transmission appears to occur over roughly approximately 8 days following initiation of the illness. Patients may continue to have positive pharyngeal cultures for weeks after convalescence. However, virus culture methods are unable to recover the virus after approximately 8 days of clinical illness. This implies that prolonged PCR positivity probably doesn't correlate with clinical virus transmission. However, all subjects had mild illness, so it remains possible that prolonged transmission could occur in more severe cases. Okay. Now, CDC guidelines are vague on how long patients with known COVID-19 should be isolated. It may be advisable to obtain 2 paired RT-PCR tests. Well, one of the, basically the nasopharyngeal and pharynx tests. Okay. All right. So where are we at? I'm going to wrap this up by going over this document's take on personal protective equipment. All right. And I'm going to try to include I'm going to include a link to this in to both of these in the description below. All right, contact precautions, some sort of mask like we discussed. Anesthesia mask may be placed in line with a viral filter. Goggles or eye shield, don't forget that. Hair cover for aerosol generating procedures. Hoods may be used, especially during intubations. See some, they said something interesting. Hoods may be used, especially during intubations. This can be constructed out of a trash bag, as shown in the tweet above. So what are we looking at? What are they? Okay, I'm not sure who we're putting the trash bag over. I apologize. I should have looked at that before I started recording the video. But it may be that, well, I'm not going to say. Look into this document and go a little further with it before going on. I'm not going to take the time while I'm recording to run this down, but that's interesting. Goggles or eye shield, hair cover, hood, shoe covers aren't recommended as removing them may increase exposure according to the ANZIC's guidelines. So that's interesting. That would be a good topic of discussion to have. Shoe covers or no shoe covers. Shoes that are easily cleaned and don't need to be touched, in other words, slip-ons, may be preferable. Danskos. Exact gear used is probably less important than using it correctly. So some pearls about, oh, wait a minute, donning and doffing. Understand how to put on, to don, and how to remove, to doff. Personal protective equipment is extremely important, especially if contact transmission is a dominant mode. Removing soiled PPE is the most critical and difficult aspect. So taking your gown off, take all of these things. There's a video in this that describes how to use your PPE You can skip the first 5 minutes of the video, okay? Some pearls about personal protective equipment. Pay attention to the junction between the gloves and the gowns. Gowns should be tucked into gloves, leaving no gap in between. Using gloves with extended cuffs facilitates this, similar to sterile surgical gloves. Gloves with long cuffs may facilitate removal of the gown and the gloves as a single unit. So as you take it off, you peel it off and turn it inside out. When removing, always start first by applying an alcohol-based hand sanitizer to your glove. So that's a good recommendation. So you got your gloves on, but you actually clean your gloves with a hand sanitizer first, okay? Create a stepwise protocol for PPE removal. 2 examples are shown below, but this may vary depending on your exact gear, okay? They've got a couple of checklists for removing PPE using a tearaway gown or using one with fixed neckties. Consider doffing with someone watching you to ensure good technique. If this isn't possible, doffing or removing in a mirror may be helpful. All right. Now this goes on. This is a long document. And it goes on to a lot more information. Some of you will be interested in just digging into all of it, and others, if you've made it this far, I commend you, but you're probably done. So I hope that this has been helpful. I tried to not just read to you, though there were important things to read, but rather to talk about these things a little bit. Again, remember, no matter where you are on the spectrum of concern or fear, always project a professional, calm, and confident and cautious demeanor and vibe to your patients so that they aren't afraid of you as well as their situation. So I guess that's the important message that I wanted to get across in that earliest part, and that is you don't want your patient to fear you. They're already scared. You want to inspire them with confidence that you are taking this seriously and you are protecting them as well as you. You don't want to look like you're just protecting yourself from them. You want to convey the idea that you are protecting not only yourself, but your work. You're doing everything that you're doing to protect them as well, or at least in their minds, to protect them primarily. Of course, you are working to protect yourself and your families and your loved ones. Thank you for listening. I hope that this has been helpful. I would have rather been playing guitar for you, but you probably would have rather listened to this because I'm not a good guitar player yet. I'm working on getting up to the beginner level and eventually joining the Bush League. So you all have a great day. I hope you are staying healthy, happy, and unafraid. Respect this thing, but don't operate in fear. Fear makes us make bad decisions. You have a wonderful day.